Good morning, all. It's such a honor and pleasure to be in the middle of eminent professionals like you. Since morning, there had been very good information-packed sessions, very heavy. I will promise you that this is a very breezy, light one. I'm Anupama from Karkinos. In Karkinos, we are a 2-year-old startup. What we are working with is mainly with oncology, and we right from early detection to diagnosis to delivery of care to doing cutting-edge research in bioinformatics using the whole genome sequencing data, which is coming from our own state-of-the-art laboratories. So you see that in this journey, we are doing a lot of data gathering. So not only clinical data, a lot of big data also. So, but though we are doing so much of data gathering as part of our organization, we are quite an young organization. From being an AIML, like since yesterday, all of us, most of the AIML professionals or ML engineers will agree that we are always greedy for data. We need more data. So even if we are going to be 20 years old, we will still need data because AI needs diverse data, not only from our own setups. So while we are doing this, we are dealing with a lot of hospitals. We have tie-ups with a lot of hospitals. Now that we also have our own lab, which is doing genome sequencing, we are also in tie-up with biobanks, where we need samples where we can actually start working with. In fact, we are working with IIT Madras for samples. So while doing all of this, one of the first things we do when it comes to when we are asking for data is a data sharing agreement. So today, most of what I'm talking about is all going to be about how am I going to have a data sharing agreement. When we have to talk in terms of creating a data sharing agreement, what are the aspects which go into it? It is not just the legal jargons. I'm talking about the spirit of how we are going to develop a data sharing agreement. So this topic is all about building a culture of data sharing. So when we say culture, what do we think? Culture is building a community. So we have, within a community, what happens is like there's a lot of processes which are very similar. We speak the same language. The thought process is similar. And it is not about, it is also about how we behave with each other. It is all kind of very similar in a particular culture. So though I come from a technology background, today, this talk is not going to be about any of the tools, technologies, or techniques which is used in data sharing. In fact, a lot of such topics have been already discussed. Professor Andre had a very nice discussion on federated learning and how do we share data across globe and all that. So, but here I'm going to only stick to the culture of data sharing. How are we going to imbibe data culture in our organizations? Because sooner or later, all of us will be on both sides of the table, the data sharer as well as the data requester. Like those CMC is having 20 years of data. Sooner, their AIML group will want data from other organizations, so as to have diversity. So always we will be in both the sides of the table. So how do we imbibe that culture into our organization? So one of the main things is, it is not, data sharing is not just, always we think in terms of, in order to share data, I have to only think in terms of tools and technologies. It is not that. It has to be in the DNA of how we think, how we are having, what kind of a mindset we have, what kind of an attitude or what kind of a behavior we have when people are asking for a data and people are requesting for a data, as well as when we have to share the data with others. So again, I'm coming back to this most used stakeholder slide. I'm sure all of us have been looking at the same stakeholders for a while now, but if each of us have to put ourselves in one of those 1 to 5 buckets, definitely one of us, we will be in one of those sections, right? So, but here I'm only going to talk about these stakeholders from a data sharing perspective. So yesterday we were hearing terms like data fiduciaries, and I'm using the word custodians here, but in a legal word, it is a fiduciary. They hold the custody of the data. Again, if you see here, in a patient-centric environment, the patient himself or herself is the data owner, and the consent comes from them. So when we are talking about data sharing, when somebody is coming, like I have been in touch with many hospitals to get their data. So how do they share data with us? Most probably they share the data in CSV files. Or maybe if they are a little bit more technologically savvy, they do it over FTP. So this is, when this kind of thing comes, then there is a lot of checks and balances we need to keep in place so that we are doing that data sharing in a very secure manner. How do we ensure those things? Those are the things which we will be discussing. So when it comes to labs and pharmacies, they are already doing standards. At least DICOM and LAWINC has been in a while, is in the play for a while. But when it comes to the lab reports, each lab has its own format. So when I'm building the data pipelines for our data lake, there's a huge number of types of lab reports which I have to deal with. So which means we have to apply NLP techniques, we have to apply OCR techniques to just get the structured data out of it to start making sense out of the data. So and health tech companies are the enablers when it comes to the tools and technologies. They're just the enablers here. How can you actually bring in the concepts or the principles of data sharing as part of your technology or as part of your tool is what we need to be looking at. And again, the healthcare professionals, the doctors, the clinicians themselves, they play the most important role. If they are not entering the data in the right way, no point in sharing it. Right? Actually, I was very surprised to see Dr. Ms. Anita's presentation yesterday. The richness of the EMR, which CMC is following, because I had been part of development of EMRs, I know it's extremely difficult to convince a doctor to enter the data in a structured format. So they're never satisfied because the workflows, what they think is very different. The workflow, what the EMR will be forcing them to do will be very different, and they're never happy normally. I don't know about CMC doctors though. But so what happens is like when we have to ensure that keeping data sharing in mind, we need to start entering, or the way we enter the data also matters a lot. The way we gather the data becomes a very important thing. And of course, the entire thing has to be overseen by legal and regulators. I'll come back to the consent. We have been speaking about the consent a lot in the last couple of days. So I'll just talk about consent when we are talking about the trust and other factors. So the way I would like to discuss this entire thing is, though I am talking about a data sharing agreement, what are the core principles we need to keep in mind when it comes to data sharing? So this is a very normal, most of it, if you see here, it's all intangible things. Like I'm talking about value, accountability, it's almost like a moral science session here. So we are talking about very, very intangible aspects of how data should be shared. This is how we build a culture. So when we actually start imbibing these values or these principles in how we are developing our systems, the way we are making our policies, that is very, very important when it comes to data sharing. So when we talk about values, today, again, Dr. Balu was talking about what are the right questions you have to ask to AI. That was for AI. I can extend the same thing to data sharing also. Pretty much the same set of questions. What is if somebody, like for example, to CMC, say a VIT, group of VIT engineers, come out to you and ask to share data with them. So what are the questions we need to ask them? So that is a very, very important thing. First and foremost is, what is the patient health outcomes you're expecting from this data? So when we were working with Head and Neck Cancer Consortium, HNCOG, so we got a set of very rich post-operative data from them. So what we had to do, so normally mostly what happens is like the hospitals which shares data with us sometimes share it with a very open mind. So we have to sit down with them to discuss about what kind of outcomes can be expected out of this data. I'm not talking about the patient health outcome per se, but what will be the kind of expectations out of working with the data of this kind. So we sat with the team and we discussed about, for this kind of data, what is the kind of outcomes we can expect. That is, in fact, precisely in line with what Dr. Andre was mentioning. So there is nothing like a good quality or a bad quality data. If you have this quality, I can go up to this kind of analysis. So the kind of data which we had, we could do some basic statistical analysis around it. So that is the kind of discussion which has to happen when we are actually thinking in terms of data sharing. Why is somebody asking for data? And what is the kind of efficiencies is this data sharing going to bring to the table? And is there a cost saving for both the patient and, like when we are talking about, yesterday there was a topic about AI in operational efficiency, AI in the reception area. So are we able to bring, operational efficiencies into our system by using, AI? And of course, at the back end, it's all about, am I sharing the data to build such models? And again, we talk about, particularly in the field of bioinformatics, a lot of data is being shared across the organizations. So it is to do some innovation in the research. When I'm asked to share data to a pharmacy, for pharma companies, then are we actually looking at what kind of new therapies are we looking at? So again, the basic thing is about the continuum of care. We are sharing data across organizations for a continuum of care. So when it comes to the accountability, we have been speaking a lot about privacy. One thing is privacy is not just an afterthought. The concern or the way we are going to do privacy is not an afterthought. It has to be the tools and the techniques what we are creating has to have privacy by design. This is a very famous principle. It's also been adopted by GDPR, and most probably our own policy makers are also adopting this technique, this framework. So it has to be proactive and not reactive. It has to be preventive and not remedial. And it has to be embedded in the design, and patient-centric is the core of privacy by design. And another thing we have to think about is privacy is just because somebody gave a consent does not mean that they give it for their life. So consent comes with an expiry date. So the way we are designing our systems has to keep that in mind. So when every query I make to the system, the first check should be, is there a consent to that? It's not like one time this patient has given consent, forever I can use this data. It's not that. So that is the reason why we say that privacy has to be by design, because the way the software or the data sharing, data warehousing or data marts or whatever is being created has to keep this in the core principle of how we are thinking. And then visibility and transparency. In fact, yesterday we were talking about the visibility and transparency part. Does the patient themselves have a way of, correcting the data if it is wrong? They should at least be able to see that certain demographic data information is incorrectly entered. Can they go ahead and, like how Aadhaar, you can, when there is a change in address, you go and you have an ability to go and correct it. So these are the things we need to keep in mind when we are actually designing a system for data sharing. So normalization and standardization part, right? So today morning, we are talking about, particularly when we are talking about data sharing, we talk about a lot of retrospective data sharing. In retrospective data sharing, we talk in terms of some 7 to 8 years minimum. Like if I'm probably requesting data from CMC, it will be a 22-year-old data. So in this, what happens is that there are so many things which change over time. One example could be like when we are talking about a TNM staging in cancer, AJCC 7 edition treated tumor sizes in different manner, whereas AJCC edition 8 is treating it differently. So if we don't take that into account when we are sharing the data, when we are not mentioning that this is coming out of AJCC 7 and this is coming out of AJCC 8, then the thing will become very chaotic when it comes to the way we deal with data. So when the moment word chaotic comes, I am putting traffic jam there because I am from Bangalore. The other side of it is also India, for that matter. So when we have normalization, how do we normalize? We ensure that the information which is needed is also part of the data. Like one example, what I told about AJCC, it could be a very, very trivial example like, am I treating the units correctly, right? So most of the standards, for example, fire, provides you with ability to mention the units. If the unit is not mentioned, imagine, we dealing with chemotherapy. You talk about a body surface area, and somebody gives in kg and you're calculating it in pounds or vice versa. It's a problem. So we need to have that normalization and standardization in picture. So when we talk about data chaos, it is again another concept which is also relevant to data sharing. Data can get chaotic in 4 different ways. One is the data silos, which is all about data sitting in individual systems, which is very, very inaccessible. You cannot find it, you cannot access it. So sharing becomes very, very, very difficult. The other one is the sprawl, where the data is available in several systems. It is not easily, you can't bring it to one place to work with it. And then the third one is the swamp. With big data and IoT-based data coming into picture, we are all swamped with data. In fact, when I was hearing about CMC has 7.5 terabyte of data, I was like thinking, in big data world, we are dealing with genomic data, and one whole genome sequence occupies around 200 GB of data, which means I can only have 38 patients in this 7.5 terabyte. So that is the kind of size of data which we are looking at. But the problem is, with that kind of sizes, data sharing is absolutely impossible. And if you are not able to take care of the data, the storage and everything becomes more of a liability. So that is where, apart from the security and other concerns, federated learning kind of concepts come into picture, because the data can sit in one place and others can actually work with it. So that way it doesn't have to go to different places for the analysis. The fourth one and the most important one is the shadow. So what is a shadow? The shadow is the data which is not managed by an IT team. So we assume we designed the application by privacy by design. We took care of all security mechanisms. We are interoperable. All that is fine. But if we are allowing a person to download a personally identifiable information, say in a report, onto their personal laptop, and they are able to share that into a personal email ID or a WhatsApp, then it goes out of the jurisdiction of a IT control. So that shadow data can be a big problem when it comes to legal issues. And now that we have created a data agreement, and now we are in a tie-up with an organization where we are sharing data from them, it is not a one-time thing. Just because we got an agreement signed or an MOU signed doesn't mean that it is a one-time activity. We need to constantly evaluate whether that data sharing is working or not. How do we do that? We run it like a project. So when we normally, from my organization, when we are getting data from other organizations, we run it as a project. We have a project plan. We have weekly meetings. We show small successes. We make it as an agile project. We keep showing them the impact what that data is able to make for us. So we start with small things. We show them, maybe start with a univariate analysis of the data, and keep showing them what their data is, and slowly keep building the practice. And then also about goals and objectives. In fact, right during our agreement, we mentioned what is the purpose of why I'm sharing the data. But is that purpose, again, is in place, or am I kind of moving away from that goal and objective? It is okay to pivot, but we need to be keeping both the parties understanding that it is goals and objectives are undergoing a change, if at all. And of course, the metrics and data quality and all of that has to be constantly evaluated. When it comes to security, what we think in my data agreement, I say, I am actually an organization which is ISO 27001 certified. I am having fantastic security in my organization. This is how I'm doing it, all on paper, we show them. Like how this guy is saying, I mean, just because you say this is private information does not make it safe. So this is where the tools and technologies come into play. So when we are actually working with, it's not just the, how we are dealing with the PIIs. So are we having the anonymizations in place? Are we having pseudonymizations in place? All of the techniques, checks and balances, are they in place? To give a small example, though we had, it's like also, it's not only the responsibility of the sharer, it's also the person who is requesting to ensure that the sharer is not giving the PII to you. Like one example was when we were working with one organization, we got PII information by mistake. But we had tools at our end which kind of flagged it, that we are getting some PII information. It's not directly. Sometimes it's not like you see it just by exploring the data. Sometimes it is embedded into a clinical note, a mobile number of a person, which doesn't have to be there, but in a couple of places it was there, the name of a person. So such information is flagged, and we ensure that that is redacted from the moment we take the data itself, we should ensure that our systems are in such a way that even though somebody shares it, we do not store it at our end. So that kind of a response, that is why I said it is a culture. Just because somebody is giving doesn't mean that you have to keep it. You need to have systems in place which ensures that you don't get into any legal issues just by storing somebody else's PII. I'm just putting the fairness, justice, trust, and respect into one bucket because it's all kind of more or less interrelated. We have been talking about data equity. We have been talking about how to treat individuals fairly. In fact, the data fairness, the word fair, what Professor Andre was mentioning about. Is the data findable? Is it accessible to people? Is it interoperable? Is it reusable? Is something which we have to keep in mind when we are doing a data sharing. And the second one is never share when you think there is a potential for misuse. How do we know that, whether there is a potential for misuse? That is where some of the data aggregators come into picture. Sometimes there are organizations which does this due diligence, whether this particular data or this particular organization is going to use it. This is where the trust and the brand equity of the organizations you are dealing with comes into picture. Are we reasonable and proportional in data sharing? So if you're actually wanting to do, all of these things will come across when you're actually asking the first question, what are you using the data for? If that, most of the answers will be, most of these things can be aligned to that question, the answer to that question. For example, when I'm actually dealing with, say, particular cancer-related data, I don't have to see, even though it is anonymized, I don't have to deal with somebody's mental health or to deal with sexual orientation of a person. It is unnecessary data for certain questions to be answered. So that has to be well thought of whenever that data agreement happens. We need to only deal with what is a reasonable and what is a proportionate data which is coming or which is being shared across people. Is the data sharing relevant to the patient needs? So when we are actually talking in terms of, we keep saying that we need data for analysis, or we are getting data to, particularly in cancer, we are dealing with a lot of personalized treatments and all that. So when you're trying to get more and more data, you need to be very, you need to understand whether it is really relevant for the patient's needs. Are we going to bring in some kind of a patient outcome for that data? The last one, here is where the consent comes into picture. Most of the times, we give people a form, a consent form. So if we are able to explain to the individuals as to how their data is going to be used, like when you're actually doing in fact, it should be treated with the same amount of importance that we do for an organ donation. When somebody is there to donate their kidney, you make them sit down and explain the implications of what the kidney donation is all about. It is with that same importance is what we have to do when it comes to the consent. They are sharing their data. Most often, people are very happy to share their data if they are knowing that their data is being used for improving patient outcomes or treatments and other things. So, but it is the duty of the clinicians to ensure that when they have or hospitals to explain why their data is shared and how their data will be utilized. So now that I've spoken about, do you have some time? I'm done? Okay, just a couple of 1 minute. So now that I've spoke about all of these things, there is one role what we normally talk about. Yesterday we were talking about a chief data officer. Of course, the hands to that officer would be a role called a data stewards. They will be responsible for doing all of this data management and taking care of ensuring that these principles, what we discussed now, are all part of the culture of the organization. So these would be the cultural ambassadors for the data stewardship. So with that, I would like to say thank you so much, Dr. Joy and Dr. Hannah. This was a wonderful, symposium. Thank you so much, and I look forward to more of these things.
Thank you very much, Anupama. We kind of run short of time, but I allow the audience to ask the questions to you when you're available during lunchtime and other breaks.
Sure.
Yeah. Okay. Do we have time? No. Can I please request you to ask her the question during the...
question I want to ask. Answer can be given. I think Karkinos is a private firm. It is not a non-profitable organization. You said you are collecting data from different hospitals. After that data, you are providing the algorithms for the public or for your private utilization?
For the hospitals again back. So the hospitals will be using our output.
Your hospital, your attached hospital, and your entity is utilizing that without the patient permission. Hospital,
no, that is where all of these patient sharing agreements come into picture.
Okay, my question is that you are incubating 2 hospitals and you are collecting the data with an agreement with the hospital, and you are utilizing the data for creating algorithms for your benefit, and it is not for the public utility. Okay.
So I don't exactly understand what is the, maybe I'll discuss with you.
Yeah, I mean, that will be better.
Yeah.
Yeah.